So welcome to the Life Planning Network meeting for April 28th. I don't see anyone I don't know, but I'll say I'm Bruce Frankel, president of LPN. It's my great pleasure to introduce Dr. Vyvyane Loh to you. She'll be talking to us today, as you know, about maintaining wellness as we age by understanding and improving our metabolic health. How do we improve our and maintain our health? What is metabolic health? We'll leave it to Dr. Loh to guide us on that. She's a remarkable person, as you'll soon discover, and a joy for me to introduce. She was born in Malaysia, grew up in Singapore. During her youth, she studied ballet, piano, drama, poetry, and attended Boston University before graduating with majors in biology and classics and attending BU's medical school, where she also began writing fiction there and during her subsequent residency at Newton Wellesley Hospital. She got her MFA subsequently at Warren Wilson College and wrote a notable debut novel called Breaking the Tongue, which was published in 2004. And Kirkus Review at the time called it one of the most ambitious and accomplished debut novels in recent memory. She went on and got other awards and grants, including the Radcliffe Fellowship, Creative Writing. Her book had been named, I think, one of the top 25 books of 2004 by the New York Public Library. But I could spend this hour talking to her about creative writing, which would be a delight in itself, but she's here today to talk to us about metabolic health. And so I might also say that she's board certified in obesity medicine and internal medicine, and is a member of the Obesity Medicine Association and Obesity Society. And the last thing I'll say is, I unfortunately her book arrived today, so I didn't have a chance to read it, but I opened it up and started reading randomly sentences. And, as a writer, I've gotten a pretty good sense of I can read sentences and tell if I'm in the grips of a good writer, and I most assuredly am. And I can tell you from watching Dr. Loh present last year at MetaBesity 2021 conference, that she's also a terrific authority on what she's about to discuss. One thing I loved was that when she was speaking to the doctors, there were about 1,000 scientists over the course of that week there. I don't know how many were on for her presentation. She delighted us. She may have disturbed some of them because of her honesty about failures to teach preventive medicine, but I'll leave it to her to take it from here. And let me just switch to the view to speaker view. And thank you very much for joining us and spending time and giving us your knowledge.
I am really happy to be here, and thank you for that introduction and for inviting me, Bruce. And I really needed that centering moment, because at the last minute, I was called upon to do what ended up being a 3-hour presentation this morning with a 1.5-hour question and answer immediately after. And then I was like, what time is it? I gotta get to Bruce's conference, right? Had to eat, run to the restroom for a break, get my water. And I was just, and so I really needed that moment to center. And there's one other thing I just discovered to my delight, because I had to set up, get my setup and make sure that I could be comfortable when I'm presenting this. And I realized, because I've been wearing heels all day, and take off my shoes, so now I'm barefoot, and I'm so much better now. So yeah, it's finally that moment in the day. Okay. So, and I'm really looking forward to this. So I did have a poem that I wanted to start with. It's a short one, so I'm just going to squeeze that in before we actually begin.
Please.
And this is one by Lucille Clifton, and it's called There Is a Girl Inside. And I really relate to this because I'm always, I think there is that girl inside, and I'm always connected to it. And even as my body ages, I am in deep communion with that girl. Okay, so here it is. There is a girl inside. There is a girl inside. She is randy as a wolf. She will not walk away and leave these bones to an old woman. She is a green tree in a forest of kindling. She's a green girl in a used poet. She has waited patient as a nun for the second coming, when she can break through gray hairs into blossom, and her lovers will harvest honey in time, and the woods will be wild with the damn wonder of it. And I needed that today too. All right.
Thank you.
So yeah, I am board certified in internal medicine and obesity medicine. And sometimes people ask me what I do, and people go, oh, what you do is more like functional medicine or integrative medicine. And it upsets me a little bit, not because of what functional medicine doctors do or integrative medicine. I think that that's very much, I do use a lot of those tools. But it's sad that when you talk about medicine, that's not really part of that world, right? And we have to pull in these other terminologies to describe something that is working towards keeping patients healthy and preventing illness. So my practice, Transform Alliance for Health, you'll see that what we do is transforming sick care to healthcare globally. And the reason that I started this practice was because I knew that what I had been trained to do was sick care. And now I needed to focus on healthcare because ultimately it's not sustainable, the sick care model, right? So today I'm going to, the presentation today is just focused on some generalities about metabolic health, but I hope that you'll leave with some specific ideas of how we can address metabolic health and therefore age well, okay? So I'm going to start with body composition. And you'll never hear doctors really talk about body composition. It's a tool that I think we're really missing out on. And we have very good ways to look at body composition, and it gives us so much information, and yet we're not using it and we're not aware of it. And patients are not aware of what's so important about body composition. So in looking at chronic diseases, a lot of people have identified obesity as a root cause of so many chronic diseases that we have. And therefore, people, providers might be telling their patients, listen, you got to lose weight. And if we get your weight down, you'll be a lot healthier. And I have to say, that's a really rather unsophisticated way of looking at this problem. Because basically, you're focusing on weight. And if you're maybe a little bit more nuanced about it, you might be talking about fat mass. There's too much fat mass. But when we dial down to it, it's not just the fat mass alone. It's whether that fat is healthy or not. Because believe it or not, we do have sick fat. And that's when we start to get into trouble. When we have too much of that sick fat, dysfunctional fat, rather than healthy fat. Now, we've depended on the BMI, which is the body mass index, to help us determine if we're in a good range, weight range actually, or whether we're metabolically healthy or not. The BMI is just your weight over your height squared in metric units. And I put up the parameters here. If you're overweight, then generally it's 25 to 29.9. Class 1 obesity is 30 to 34.9. Class 2 is 35 to 39.9 and so forth. And class 3 obesity is 40 and above. And it's a great population index. Maybe it's really good for the public health people, but there are big differences that are based, for example, on ethnicity. So if you are South Indian, if you're from India, for example, you'll see that overweight here is 25 to 29.9. But if you're South Indian and you have a BMI of 25, you are obese. I'm East Asian. So a BMI of 27 in an East Asian will put you in the obese category. So you can tell that, okay, this is not going to be very helpful if we're not looking at a homogeneous population, right? And also, we don't know where that weight, you see it's weight over height squared, where that weight is coming from. And that's going to make all the difference in the world. What will be more helpful is to look at the percent body fat. So how much of your weight is coming from fat? Okay, because your weight could be coming from fat, from water, from organs, from bone, from muscle, right? And what we want to know is actually how much of this weight is coming from fat. So we're trying to determine first and foremost the fat mass. And if we use the percent body fat, although we still have some variation with age and gender and ethnicity, in general, if we see that you are male and your percent body fat is 23 to 25%, that's really the cutoff. Anything above those numbers, I tend to veer towards the 25%. Above 25% puts you in the obese category. And this is the part you should underline, regardless of your weight. I don't care what your weight is. If 25%, greater than 25% of that weight comes from total percent body fat, then as a male, you would be obese. For females, I tend to go with 35%. Now let's look at this study. Maybe this will make it clearer for you why this is important. This is a study from 2014 out of Italy, and they were looking at a population of women between the ages of 30 and 40. And if we went just by the BMI, weight over height squared, then 30%, about a third, were classified as obese. But if we looked at the percent body fat using that 35% cutoff, then 82% of the exact same population was classified as obese. Okay, so we went from a third to pretty much everyone, just like that, okay? And it was the same, when we looked at other studies. This is NHANES 3, and this is from 1988 to 1994. So quite some time back. But at that time, they had about 13,000 plus subjects. 21% of men and 31% of women were obese, again, just by that BMI criteria. But if we applied the percent body fat criteria, then 62% of the women and 50% of the men, right, were now classified as obese. And take a look again at that timeline. It's 1988 to 1994. But where we are now in terms of prevalence of obesity, in 2018 in America it was 42%. Post-pandemic, we moved up, folks, to 45% by BMI. Okay, so my guesstimate for percent, if we use the percent body fat criteria, then 95% of the American population, regardless of weight, suffers from obesity. And that actually matches with a study that came out of the Gilling School of Public Health, I think at the end of 2018, if I remember correctly. In that study, they actually came up with a number of 88% of Americans have metabolic dysfunction. So 90%, 95% body fat. We're kind of very close. All right, so you can now see why COVID has been such an issue. And two, the future does not look good. Okay. So besides the total percent body fat, where that fat is also going to be vital. So compartmentalization of fat, right? because there are different places that we can hold that fat in the body. Now, ectopic fat, ectopic just means out of place, right? And this is fat that is where it shouldn't be. So you can see in this, in the diagram, for example, picture of the liver. Now, liver should have liver cells, shouldn't have fat cells in it, right? So the fat cells in here are out of place. It's ectopic, shouldn't be there. And it's very toxic, as you will see later. And we can see this in pretty much any organ system: liver, pancreas, heart, muscle. Okay, so if you have fat in your organs, really, you're in trouble. Shouldn't be there. Now, a subset of this ectopic fat is what we call visceral fat. If you look at this drawing, you see this yellow portion here that's labeled subcutaneous fat. Subcutaneous just means under the skin. So it's right under this blue layer of skin here. And anything you can pinch on your body, the muffin tops and everything, you know, you might not love the look of it, or it might frustrate you as you're trying to get into your clothes, but that fat is actually protective and relatively healthy, okay? And that would be the subcutaneous fat again. Then after that, you have this layer of the muscle wall, the abs, your 6 packs live here, 12 packs for some of us. But right inside the abdominal cavity, now this is inside the belly now, right? That would be the visceral fat, which is a subset of ectopic fat. It's a subset of fat that shouldn't be where it is, okay? And it's called visceral fat because it's this curtain of fat. I'll show you a picture later. It's a curtain of fat that lays over your intestines, right? Now, where that fat is, I just said the compartments that you find in, whether it's subcutaneous or visceral, or maybe in the organs, makes a big difference. Here's why. Because the function of that fat is going to differ based on where it is. So with fat cells, you know, these adipocytes, really, it can grow in a number of ways. And you can actually have more baby fat cells, right? So you start with a pre-fat cell, pre-adipocyte, and then you make more fat cells, right? So you kind of reproduce that way. And that process is called hyperplasia. So we're making more baby fat cells. And some people will ask me, well, I thought you could never grow any more new fat cells. And that's not true. You can make new fat cells in your body, and you do that. Another way that the fat can grow is by this process of hypertrophy, which means instead of making more baby fat cells, we're going to just swell bigger. Okay, so you still have one fat cell, but you can see it's a much bigger fat cell now. So there's more fat in that cell. So there are two ways for the fat mass to increase. Either we make more baby cells, or we just become a bigger cell. Right, and this is just another diagram to show the same thing. But this is the analogy I want to use. Okay, if you pretend you live in this housing development, all right, and everything has been planned out, the sewer lines laid out, X number of bathrooms and things like that. But what if everyone secretly decided we're going to add new bathrooms, and we're not going to tell the town planning board, and we'll just kind of sneak it in, you know, because it would be more convenient. So everyone decides we're going to add 2 or 3 new bathrooms to the home. You can imagine straight away you're going to have problems with what? The water pressure, for example, right? And the clearance, the sewage lines are going to be, a lot more clogged, okay? And that's exactly what is happening here. So if you see, here are the fat cells, and we make more new baby fat cells, then part of that is you also make new blood vessels. Okay, so as you make the fat tissue and you grow more baby fat cells, you have more blood vessels to support and bring nutrients and oxygen to those new baby cells. All right. But if we go with hypertrophy, where the fat cell just swells, we're stuck with the same number of pipes going in and sewer lines. You see what I'm saying? So as a result, we now have a bigger volume of cells, right? And not enough blood vessels to supply those cells. So then we're going to have the situation of hypoxia, which basically means not enough oxygen is going to get to those cells. And you know what that means. That's not a good thing. No oxygen that's why we can't live on Mars yet. Yeah, we all know that. So, okay, so we have the situation where not enough oxygen, but also not enough nutrients, because that's the other thing that the blood vessels are bringing to cells. So not enough of nutrients and minerals and so forth and cofactors to support those cells and the functions that they do. And then clearing the debris and the waste products of the cells will be a problem too, because now your sewage lines get clogged as well. Okay, so this is the situation if you have hypertrophy. If you have hyperplasia, at some point, this will cross over too, but in general, this is a healthier situation because you're also making new blood vessels as you're making the new baby cells. And because these cells here, the hypertrophic cells, aren't getting enough oxygen and nutrients, they're going to be sending out distress signals. Okay, and these are the pro-inflammatory cytokines. And basically, they're sending out signals that say, help, we're dying. We're clogged up with debris. We're clogged up with a lot of toxic substances, and we're in trouble. And this sets up the process of inflammation. And when you go into an inflammatory state, you are revving your immune system up to attack, destroy, clear out damaged tissue or invading organisms. Okay, so it can be very helpful if you have been infected by a virus, for example, but it can also kind of spin out of control. Now, in this case, it's a low-grade inflammation, it's chronic. So it's just always simmering, okay? But you never turn off the inflammation. So you always have this brew of inflammatory cytokines now, bathing your organs and everything in that area. And my main point here is that ectopic fat is sick fat. It's dysfunctional. It's not doing the job it needs to do, and it is damaged tissue, and it sends out these distress signals that really increase the inflammatory state in your body. And in fact, what is happening is the fat is dying. Okay, because I told you there's not enough oxygen going in, there's not enough nutrients going in. And so those cells, as a result, will now begin to die. And necrosis, is basically the process of death. And we see that in the organs where that fat is, because that is sick fat, that ectopic fat. And you see these black areas. Essentially, what you're seeing is gangrene. You've seen gangrene of the foot. It's all, the black digits and fingers and toes and that kind of stuff, right? Here is the visceral fat that I told you about. And this visceral fat is overlaying the intestines, right? And you can see these black areas, and this also would be fat necrosis happening. This is dying fat. So if you have a lot of visceral fat, you have a lot of fat tissue inside your body that is distressed, damaged, and dying. And this is what it looks like. I'm just going to skip this slide. And it causes a lot of metabolic dysfunction is all I'm going to say from this slide. I didn't want to go too much into it. But the VAT, which stands for visceral adipose tissue, right? That's the visceral fat because it's the ectopic fat. Remember, the subcutaneous fat isn't doing that because it's multiplying by the extra baby cells and then new blood vessels forming, right? It's mostly the ectopic fat that's just swelling, and there's not enough blood supply and not enough oxygen and nutrients to it. We use visceral fat, visceral adipose tissue as a good way to kind of, guesstimate the amount of ectopic fat in your body. Because if you have a good amount of visceral fat, you probably have fat in your organs as well. Okay. Now it's hard to probe and study, you have to put people through CT scans or MRIs, not very feasible and sustainable. But the VAT, you'll see later, it's easy to assess the VAT. Very, very easy and pretty much no risk method to assess VAT or visceral adipose tissue or visceral fat. And so it gives us a window as to how much general ectopic fat you have. And that's why people are focusing on this visceral fat, in terms of looking at your risk for all kinds of disease. This is just a paper that tells you that now we know that if you have more visceral fat, then your risk for inflammatory bowel disease like Crohn's disease and ulcerative colitis go way up. Because again, that fat is toxic, it sets up an inflammatory situation, and then you have damage lining of your intestines and all your troubles start there, right? This is another slide just showing the same thing with IBD, inflammatory bowel disease. But what about something like cancer? First of all, 40% of all cancers are related, globally, are related to obesity. I don't think a lot of people know that, right? We spend a lot of money and resources in developing new cancer treatments and drugs and so forth. And yet, if we focused on this root cause and addressing this root cause, right? And many of these strategies for doing that do not really involve medication, and they are lifestyle changes that will make a huge difference, then we can actually address 40% of all cancers. And that would be cancers like all the reproductive ones, endometrial. So one of my closest friends from med school, she's OBGYN, and she said 50% of endometrial cancers, uterine cancers, are from the visceral fat. Okay, breast cancer too. Right now, with breast cancer, it's really interesting because it's also, and I'm sure I don't know if there were other studies looking at other reproductive cancers, but I do know of the one from breast cancer where if you are normal body weight, but you have increased percent body fat, your risk is still elevated. I don't care what your weight is. I don't care what your BMI is. That percent body fat is still above the 35% for women, then you are still at elevated risk, right? Ovarian cancer, same thing. Prostate cancer, same thing. Colon cancer, pancreatic cancer, multiple myeloma, gastric cancer. I mean, I don't quite want to go on because it probably is a little depressing, right? This study was interesting because they looked at women with breast cancer. And what they noticed and the results that came out of this study was really that it was the subset of women that had increased visceral fat that had spread of the cancer to the lymph nodes, breast cancer patients. So if you had increased visceral fat, then you were more likely, way more likely. In fact, in this study, yeah, all of those who had lymph node positive breast cancer had really too much visceral fat. Okay. And we can't go by waist circumference because what this slide is showing you is that all the men here, the MRI slices, have the same waist circumference, and yet they have different amounts of fat. Right? So you can't just say, oh, if you are at this waist. Now, obviously, we still use waist circumference because it's very low cost screen, right? And if the waist circumference for a man is, I don't know, for a man actually technically greater than 37 inches, then International Diabetes Federation would say you have metabolic syndrome. Okay. For women, I believe it's 31 inches. So I have to go back and look, but it's a good screen, but you still can't really tell because again, this person didn't have a lot of visceral fat, but this person, way more, and they're the same waist circumference. So, and this is our idea of obesity, right? Which is why there's so much stigma and a lot of shame, and it's just this very uneasy conversation or lack of conversation between providers, right? And patients. But really, we should be thinking about obesity in someone who looks like this. Okay, because this poor patient will get probably nagged a lot about weight. This one, oh, you're fine, right? Until these are the ones that could do, oh, well, he wasn't even obese. Really? Let's take a look. So this is a DEXA scan. It's the same thing you do for bone density, except you can look at it, you can look at body composition. Now, most places don't do this. I don't know if they know how to, but I certainly have had challenges getting places that do bone density to do a body composition. We happen to have our own DEXA, so we just put our patients through it. It's an X-ray. The radiation levels are so low, they're about 1 day's ambient radiation. You get in an airplane, you fly to California, that's 1 week's ambient radiation exposure in the 6 hours that you're in the plane. Okay, this is about under 1 day. Okay, so it's basically nothing. And we even do DEXA body comps on kids. Okay. No shielding is necessary. The Department of Public Health doesn't require, because it's really non-invasive and there's not a lot of radiation at all. So it's an easy way to screen a patient, and we can follow the patient. More importantly, you can follow the patient sequentially because you're really not exposing them to anything bad. See what I'm saying? You can do them, in a month, and it's not a big deal. Okay. So this patient that we just saw in this picture, right? This is his DEXA, and waist circumference was this, and hip circumference was this. The BMI was 27.7, which, if we go by the regular criteria, puts him in the overweight category. Percent body fat, he's right on, that is right there at the defining 25%, right? If he were 26%, he'd be in the obese category. He's just kind of right there at the 25% mark. But the VAT, the visceral adipose tissue, is 127, the area. Okay, you can see that number here, I hope. 127. If your number for VAT is 100 and above, you're at high risk for cardiovascular disease, stroke, cancers, diabetes, all that bad stuff. If it is greater than 160, then you are at extremely high risk. My preference is to get them below 80. And the reason for that is most of my patients come to me already compromised with diabetes or, cancer or hypertension and so forth. So I like to get them below 80. And honestly, just in my years of treating all these patients, the lower the better. I don't say 50 because it can be very discouraging. I would say a large number, over, 2/3 of my patients come with VATs above 200. So I don't say get it to 50 because I think that can be very discouraging for the patient. And I work my way down to 100, and then I work my way down to 80, and then we have that discussion. Okay, but at least, for today's talk, think about 80 as the number. Okay, so after we treated him, here are his new numbers. His BMI is 25. Who cares? But the percent body fat is 21.3%, and the VAT is 80.5. Now, by the way, I want to go back. I don't know if you can see this. It's pretty hard to see, but this is a little pinker because there's more lean mass. When you see more yellow in it, that's the fat, right? So his VAT is now 80.5. He was diabetic. We got him off meds at this number. Okay, got him off meds, right? And normalized his A1C and everything. But no one would have thought to tell him that he had an issue, right? Because he looked skinny. This is a 13-year-old. I thought it was interesting to show a pediatric patient. And she was, forget the BMI, but she was greater than 95th percentile with the growth curves for her age, which basically put her in the obese category. And percent body fat was 44.8%, and visceral fat was already 109. Okay, so we were at a place where we better do something. Now, this is the yellow I'm talking about. This is subcutaneous fat because it's right under the skin. After treating her for 6 weeks, her BMI was 22.8, it was just above the 85th percentile, just almost in the normal range, okay? And her VAT, visceral fat, was 86.8. And this patient, she's first year in college, studying nutrition now. There's another patient of mine, and again, we had treated him already. And after treatment, we're like, okay, are we done? Percent body fat, 32.8% for a male. You tell me. No, we're not done, right? Well above the 25%. VAT 123. Are we done? No. No. Again, look at the yellow here, a little bit of subcutaneous, but most of his fat is going to be here, visceral fat. And here we are now, BMI 25, but percent body fat went from 32 to 27.7. Closer, we're almost there. But the VATA, 86.2. Okay, so his risks are much dramatically decreased at that VAT. Now I'm going to switch gears because I've been talking about fat for a while. But now I want to talk about muscle because we're talking about body composition and the main components here. We could talk about bone too, but today I just want to focus on fat and muscle, all right? Because this is vitally important in aging well and maintaining your metabolic health. Sarcopenia means lack of flesh, sarco, flesh, penia, lack of. So, you know, but in the medical term or terminology, we're specifically looking at lack of muscle or loss of muscle, okay? So that's what we mean when we say sarcopenia. And, you know, maybe 5 years ago when I talked about sarcopenia, everybody went blah, 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 enough, okay? And now everybody's like, oh my God, sarcopenia, right? Although in Europe, they were really jumping onto this a lot earlier because it's a mortality predictor. And we know this now that if you have low muscle mass, you are much more likely to die, right? Within a certain time frame. So when you have low muscle mass, if we translate that into common language, what we mean is that you're frail. And if you're frail, you're not going to bounce back from any kind of insult as easily, okay? Now, the traditional sarcopenia model, as modeled here in the dotted line, says that after the age of 40, you kind of lose 3 to 8% of muscle mass per decade, 3 to 8 pounds per decade. But actually, that's not quite really what happens because in real life, people have what we call catabolic crisis in their life. So for example, if they get sick and they're hospitalized for pneumonia, right? If they have increased inflammation and insulin resistance, if they're bedbound for some reason, okay, then they're going to be following this bottom line here, which is an accelerated muscle loss line. Okay, and that's what we mean when we say they suffer from these catabolic, you know, you catch pneumonia, you catch the flu, and you lie in bed a few days, and that's going to accelerate your muscle loss. So actually, people are losing muscle at a higher rate than what the traditional model projects. Now, you know, we do a lot of studies in old people, we do studies in young people, but what about someone like this in the middle, 50s, let's say, or 60s, you know? What about them? Nobody really looks at them. You know, if you look at studies, nobody's interested in that age group. And the assumption is, okay, if we look at this, right, we're talking about inactivity in young people here, and they don't lose very much muscle mass. We're looking at the loss of lean leg mass here. That's not that bad. 28 days of inactivity, and you know, they lose some, maybe just about 500 grams, maybe not even that. Elderly people, 3 days of hospitalization, and you've lost about 10% of the lean leg mass already in 3 days in the hospital. Now, the shocking part is, remember those people in the middle, the 50-year-olds? 10 days of inactivity, and that's 10% decrease in lean leg mass. Not good. That's 10 days that you're sitting around, you didn't do that much, and it's equivalent to 3 days of bed rest, hospitalization for someone in the 70s range. And to make things worse, if you have chronic diseases, in this case, I just highlighted diabetes, right? You're going to have even more acceleration in muscle loss. So because when you have diabetes, that's a chronic inflammatory state, that chronic inflammation is going to damage more muscle tissue. Okay, very, very quickly. Now, in the case of diabetes, this is particularly important. But even if you don't have diabetes, if you lose muscle mass, this is highly important. Now, I'm just going to give you a little demo here. So if we take this bottle of water, and this is a fixed volume, and we say that this bottle, the volume of this bottle, represents the total muscle mass in your body. Let's just use that, okay? Say this represents all the muscle in your body. Now, when you eat carbohydrates, or your liver also makes glucose, right? And it gets into your bloodstream. This really, it floods your bloodstream, and your body makes insulin to help the glucose go into cells so that it doesn't stay in the bloodstream, because when it stays in the bloodstream, it destroys blood vessels. At Transform, we tell people, the analogy we use, when you have glucose, lots of glucose floating around in your bloodstream, that's really like having razor blades in your blood vessel. And I'm not kidding. Okay, because people go, well, inflammation, Dr. Loh, what does inflammation mean? Okay, let's just be concrete about it. Let's say I have a cut on my skin. The first thing when you cut, what happens? Bleeding, right? Bleeding. So, but your body wants to protect you. You're not going to bleed out. You don't want to bleed out. So your body says, oh, let's clot that blood. Right? So now you have hypercoagulability, clot that blood so you don't bleed out. Correct? Then you'll notice maybe that, that area becomes warm because there's increased blood flow to the area to bring the immune cells to the area. So now increase in temperature, and those immune cells also send out signals that cause you to have more increase in temperature and maybe even a fever. Those immune cells, because they rush to that area, they cause swelling, right? And because of that swelling, it presses on nerves and so forth, there's pain. The redness, because again, more blood flow. So these are all signs of inflammation when you cut yourself externally. But inflammation internally is the same thing. So now if we cut the blood vessel inside, think of a tube here, pretend that's your blood vessel, and those razor blades are floating in the blood vessel, and they cut the blood vessel, then they bleed. So we don't want to bleed, so we'll try to clot. Right? And any inflammatory state is hypercoagulable. So when people talk about the clotting that happens with COVID, well, that's any inflammatory state. It's not news to anyone if you studied immunology. Okay, 101, right? So it's hypercoagulable state. So you have more clotting. White blood cells or immune cells flood to that area. They send out signals, we need more help here, right? They send out signals that increase blood pressure because they think maybe, you have an infection going on, and the increased blood pressure sometimes, increased temperature is not good for the microorganisms, the invading pathogens. So that's a protective response in your body. Yeah, there's swelling in that area as well. So all these things are happening inside your blood vessel, and that's basically killing off the blood vessels and damaging them. So we don't want that. So your body as a protective mechanism makes insulin, and insulin's job is to just clear the glucose from the bloodstream. Let's shove it into cells. Now, insulin can shove it into 3 types of cells: liver cells, muscle cell, fat cells. Okay, insulin's got those 3 places: liver, muscle, fat. Okay, well, we can shove it in fat, and it's primarily subcutaneous fat, good for us because, you know, it's helpful. Not the best situation, but still helpful. Better than having the glucose in the bloodstream. Muscle is going to be your biggest reservoir. Okay, so let's shove as much sugar as we can into muscle. And hopefully, as you walk around, as you go up and down the stairs, you'll use up some of that glucose too. So remember, if this is the total volume, get this in view of the camera, of the muscle in your body. And if I decrease the volume, unless I cover this up, now we have a much smaller volume, it's half that volume. Okay, you're eating the same thing, you're doing the same thing, but because you now have less muscle, there's less place for the glucose to go, and it's still going to stay in your blood vessel. We got that? It's really important to learn, because as people age and go, I eat the same thing, right? But suddenly I'm pre-diabetic. And look at me, I'm not even overweight, right? At this point, I was driving a friend of mine, she's also a physician, and I was talking about sarcopenia and blah, 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 and blood sugar. She grabs my arm as I'm driving. She says, oh my God, that's why I've been getting more and more pre-diabetic. I eat the same thing. I hardly eat, right? Because what do? The depot, the reservoir for where we can push the sugar to is now a smaller reservoir. There's nowhere to put that glucose, and it's going to remain in the bloodstream. Okay, so we are going to, as we get more and more sarcopenic, become more and more challenged and disabled metabolically. And that's true also for all kinds of chronic diseases. Diabetes, for sure, chronic renal disease, right? We know, and I have a lot of colleagues that are nephrologists, actually, that if you address the sarcopenia and you reverse the sarcopenia, at least stop it, the kidney disease improves. Okay, this is true for heart disease, lung disease, cancer, liver disease, autoimmune disease. Right? If you don't address the sarcopenia, you're in trouble. Okay, that accelerated sarcopenia also has a different name. We call it cachexia. It's profound wasting. We see that particularly in cancer. We also have cardiac or heart cachexia or lung cachexia or pulmonary cachexia, right? So when we look at cancer cachexia, for example, I just want to point out that 20% of cancer patients, take all cancer patients, 20% of cancer patients will die from the profound muscle wasting. Not from the cancer, not from the treatment, not from side effects, not from complications, from the profound muscle wasting. 20%, 1/5 of all cancer patients. And that is why cancer cachexia, right, is something that every oncologist dreads. We have cardiac cachexia, those people in heart failure, right? As they lose more and more muscle, then the mortality increases. Pulmonary, the people with COPD, emphysema, and they have a lot of profound wasting. Yeah, that's going to be predictive of mortality. Chronic renal disease, same thing, right? Nephrologist friend of mine just kind of said, oh yeah, you're right. I read this paper and it says that if you have sarcopenia prior to kidney transplant, yeah, they don't do well. They die afterwards. And I said, yeah, that's very serious. So do you check for sarcopenia before kidney transplant? It's. I said, no, we don't. I said, why not? He said, I don't know. Okay, that's a problem, right? Same with cancer, though. They don't check it. And the only chance really that you have to treat it is when they're in the pre-cachectic phase, but you'll never know. And here's why. Because we have this condition that's very common called sarcopenic obesity. Again, NHANES 3 was 1988 to 94. This is very old data, right? And basically, what we're saying here is that this is appendicular lean index. It's a way to look at the lean muscle mass, right? And what we find that with people who have obesity, they also have muscle loss. They also have sarcopenia, right? You will never know this unless you actually do a DEXA, because this is what they look like. Okay, so you take this patient here, just because she's easiest for my cursor right now, and say she has some devastating cancer, and say her BMI is 34 there, and say she loses some weight and she goes down to a BMI of 30. Okay, she's going to look like she lost weight. Okay, but she's going to look pretty okay. She's not going to have that gaunt, wasted look that we associate with the profound wasting of cachexia cancer. So you think her oncologist is going to pay attention and say, no, maybe she has sarcopenia. No, we're not even going to know she has sarcopenia because we never checked for it. And if we go by the eyeball test, we're never going to catch it. We're going to miss it, right? So to grow muscle hypertrophy, it has to be a balance between anabolic and catabolic processes. Anabolic would be building up tissue. Catabolic would be breaking down tissue, okay? So if you're too catabolic, then you break down too much tissue, in this case, muscle tissue, and you lose muscle. We want to build muscle, then we want an anabolic process. There's always both going on, both anabolic and catabolic processes basically are under the Department of Metabolism, right? And it's always, both are always occurring at the same time, but it's the net effect. And we want, in the case of muscle, more anabolic effect than catabolic. And by the way, in cancers, you want obviously more catabolic effect than anabolic, right? Usually cancers are this proliferation of tumor cells or malignant cells, and they grow a lot. And that's an anabolic process. So it depends on the tissue you're looking at, right? But for muscle, if you want muscle to grow, you want more muscle anabolic processes than catabolic processes. All right, so if we look at physical activity here, here's bed rest, right? And it says 3% loss in whole body mass over 10 days. And then references the study. Okay, and then, you know, as the steps go up, we see that, okay, well, here you still lose up to 3% of lean leg mass loss over 2 weeks and so forth. But I want you to look at 2,000 steps here. Here's why, because a lot of my patients, when they step into my clinic, they're at about the 1,500 to 2,000 steps a day level. This is very, very common in the patient population I see, okay? And what it says here is not protective against bed rest induced muscle loss. Let me translate that. This 2,000 steps, because you know, where I was like, you know what, 10 steps is better than 0. 100 steps is better than 10, right? So here's 2,000. Yes, 2,000 steps is better than 0. No, what this is saying is, no, this is the same as 0. It's not protective. This is the same as you lay in bed all day. I was shocked when I saw this, like, what? And I had to revise my recommendations. Okay, this is startling. I don't want to go through this, but essentially we looked at older adults, and there's studies that look at young adults, and metabolically they're in a worse place after very short periods of time, right? Here in young people, 1 day of limited physical activities, it's kind of bed rest almost, increased insulin resistance by almost 40% 1 day, okay? And this is in young people, it's worse in older people. Now I want to get to what do we need to do then to address that? In terms of the sarcopenia, what we definitely need to be considering would be the nutrition, in this case, protein, because muscle is made of protein. So if you're not going to eat your protein, you have no building blocks for your anabolic or building processes. Okay, so having the protein meal with resistance training for both young and old is a good thing. It'll help you with muscle synthesis. Okay, with just meal alone, yeah, it's helpful. The protein is helpful. But if you add the resistance training on top of that, you get a better effect, right? This because I made this slide for my patients. What happens if you break Dr. Loh's 30? They know they have to eat 30 grams of whole protein per meal. And the reason is, okay, if you're young and you're at 25 grams, right? This, if you look at it, this is the net balance. This is actually looking at, it's a proxy for muscle synthesis. Okay, so if you give them like 20 grams of protein per day, then this is the amount of muscle synthesis they get. But if someone is elderly and you give them that same amount of protein, they don't get the same amount of muscle synthesis. Okay, this we call anabolic resistance. As you age, over the age of 35, we are all more and more anabolically resistant. We have a hard time putting on muscle mass. In fact, the process is more of breaking down muscle. Okay, so if you don't get that 30 grams, and in fact, in my older patients, I go higher than 30. But if you don't hit a certain amount of protein, you're in trouble. And details matter. What this is showing you is the distribution of protein. So breakfast, lunch, dinner, right? 30 grams, 30 grams, 30 grams. And this is how much protein muscle synthesis you have. Now, this is very common in America. You hardly have any, here it says 10 grams of protein for breakfast. Actually, very common to have 0. Someone just ate oatmeal. There's no protein there. Okay, so let's be nice, 10 grams. And then at lunch, 20 grams. And then at dinner, we have a big meal, 60 grams, right? But look at where you don't have any synthesis most of the day, and you have about the same as this one meal here. So how you distribute that protein is also important. So all these people who eat breakfast like this and a big dinner, yeah, and that's why folks, hate to tell you this, intermittent fasting, nah. Okay, the truth. Okay, here's an even intake again, and this is the muscle synthesis level. But if you skew the intake, then you see much less muscle synthesis, both in young and old. Okay, and basically, I put this slide here. A diet with more pro-inflammatory potential associated with it. Yeah, you eat inflammatory foods, then you're just going to shred your muscle, kill your muscle cell, right? And that's just basic. And you saw that slide where you have to have the certain amount of protein, but you also have to do the resistance training, which is working against a load, whether it's using a machine like this, dumbbells, bands, or body weight. You have to incorporate that. Why do I insist on this? Because most people, when they think of exercise, are going to talk and think about cardio and cardio alone. Okay, so they get on the Stairmaster, or they get on the bike, or they're on the treadmill, they go for a walk or run or whatever. That's great, but you need the resistance training. And I also want to caution you here. So I had a recent consult just a few months ago. The patient he's in his 60s, but he's an elite athlete, right? Nordic skier, in the elite category for his age group. And he is lean, he doesn't eat carbs, and his A1C kept going up and up, and his fasting blood sugar kept going up and up. And his doctor's like, oh, so they had a special consult. We did it by telehealth. It was in another state. The person called me, and the doctor's on the same call, and they're both together, and they're like presenting all this information, and they're like, said the doctor, look at him, he's fit. I said, fit for what? He's fit as an endurance athlete, right? But in terms of metabolic health, he isn't. Why? Because the endurance activity that he was doing, he was skiing about 8 hours a day, or biking 8 hours, depending on the season. And he ate 1 meal a day. So our friend was losing muscle. Okay. And the more muscle he lost, right, the higher his blood sugar and his A1C. Because you saw the demo with the, right, the bottle. Now less muscle, so that sugar is floating around in his bloodstream. It was as simple as that. Okay. But here's the catch. I said, listen, I can tell you what's wrong. It's going to be really hard for you to change your behavior because your identity is as an elite endurance athlete. And I'm telling you, if you're going to preserve muscle mass, you have to cut the endurance. You have to do resistance training and you have to have more rest because you don't build muscle without the rest. Because you go to the gym and you do your resistance training and you damage the muscle tissue. And in the process of repair, right, and in the context of enough protein, right, then you can rebuild a bigger muscle. But you need time to do that, and therefore the rest period is very important. But if you are skiing 8 hours every day and then you go to the gym and you do this, you're just going to shred muscle and you don't have building time. You don't have anabolic time for the muscle mass. Okay, so these are details that we do need to pay attention to. I'm just going to stop here and see if people had questions, or if that was useful to you or helpful to you. Happy to hear your comments.
First of all, that was fabulous, Dr. Loh. Thank you very much. I learned a lot, and I'm sure everyone else did. I did see one question already, which was from Marcy.
Yoga?
Yes.
Okay, the question is, does yoga count towards resistance training anyway? Okay, depends on the yoga, right? The yoga where they tell you, you put the eye mask, you put the legs up on the wall. Yeah, not that yoga. But the one where, lowering very slowly to the ground, right? Where you're in warrior pose for a long time, your legs are shaking. Yeah, because body weight does count as resistance training. If you're doing a push-up, you're pushing against your entire body weight. Right? If you're pulling up, you're pulling your entire body weight up. So that is resistance training, but it has to be at a level where it's challenging the muscle. And if you do it every day, you're doing what that endurance elite athlete, right? So you're going to have the restorative yoga, and then the next day you can do your more demanding Ashtanga, and then you go back to do a more restorative, maybe a yoga nidra practice. You're going to have to move those around a little bit.
Any other questions? You can raise your hand and I'll call on you if there is.
There's mine about swimming.
Yeah, the swimming. The swimming, okay, that's a little tricky because yes, you are working against the resistance in the water, but if you're swimming every day, you will have slight hypertrophy for a period of time, and then you're kind of going to plateau. And if you keep swimming or you keep pushing yourself in the swimming, you might have some loss as well. It's kind of, again, analogous to the endurance athlete, right? The competitive swimmers, they're also in the gym. Mm-hmm. Right? They're also lifting weights, and they have a very prescribed regimen where they have to balance the time in the pool with rest periods and so forth. So you see all competitive athletes, we always hear about their training regimen, maybe their diets and so forth. No one talks about their sleep regimen, and it is pretty intense. And no one talks about their rest regimen, and it is very intense too. It's very prescribed because you can't be in the elite category and not pay attention to those details.
Great, Barbara and Kendall. So Barbara, then Kendall, be great.
Yeah, hi, Dr. Loh. Thank you so much. What comments do you have about patients who put on weight due to psychotropic meds, psych meds?
Yeah, that's very tough. I will say that I always will consider metformin when someone is put on any of those medications, because I know they're going to put on weight in all likelihood. That's number one. Number two, I do have a fair number of patients who are on those medications and have been very successful, but then, we really have to pay attention to all the details in terms of nutrition and exercise and rest and sleep, right? You really cannot let any part slip. And maybe getting to goal will take you a little longer than people who are not. But I will say, those are the patients I treat. So it's not a lost cause, and certainly it's not, oh, just because I'm on these medications, there's no hope. Absolutely no, but it may take you longer to get there, and it will be a little harder to stay there, right? So we have to pay attention to all the details.
Okay, thank you.
Yep.
Kendall?
Interested in the protein part. I mean, a lot of things don't come labeled 30 grams of protein. Do you recommend protein powder and additional sort of supplements, or should I just stick to making sure that looking at labels and whatever that I get that amount of protein?
So with whole protein, 25 to 30 grams of whole protein would be about 4 ounces cooked weight of chicken or beef, or and with seafood you got to go a little higher, so it's more like 6 ounces cooked weight of seafood. However, because as you age you have anabolic resistance, I go higher with my older patients, and so we're closer to 6 ounces cooked weight for the chicken and the turkey and the beef and so forth.
What about vegetarians?
And 8 ounces. Okay, I'm a vegetarian. I do fish now occasionally, or seafood occasionally. And my protein sources were dairy and egg. If you are vegan, I desperately wanted to be vegan. I did everything I could, looked at the literature, crunched the numbers, could not make it work. And I cannot with a clear conscience recommend it. So, and I desperately wanted to be vegan and make it work.
What about protein powder?
Protein powders, again, you have to look at the protein source. Dairy is what I normally use, dairy sources. And you would definitely have to look at the label, but you also want to make sure you don't have a lot of carbs in that. So sometimes people will buy these protein supplements, but the quality, either the quality of the protein is not good, or there's a lot of carbs in that and they add a lot of sugar just to make it yummy or whatever, right? So the nutrition information, we're pretty specific with our patient population. But if I may, I'm just gonna let people know that I'm planning on starting a podcast in July, and I will keep Bruce informed about that. And this podcast will be sessions like this, right? Deep dives into certain aspects of health. So I'll give you an example. I may spend a whole month once a week, a whole month on hypertension. And I'll give you a deep dive, and I'll tell you what's happening in your body, and I'll tell you what you can do about it, and how you can work with your doctors, and the questions you can ask, and maybe some of the tests you should be asking about, right? And we'll do that, let's say for the month we will do, let's say hypertension. I'm probably going to spend a month on body composition, and then we will talk about the protein specifically and so on. So that's what's coming up in July. I will keep Bruce informed, and if that's the kind of information you find helpful, then I hope you will subscribe to the podcast.
Great.
Thank you. Thank you so much.
A couple more questions, Dr. Loh. Yes. Connie Bear. And then
sure. Thanks. Where can we learn more about some guidelines for resistance training? How much, how long, what our goals should be?
Yeah, again, that will be in the podcast, but generally I will say 3 times a week. And you want to make sure they're not consecutive days, unless you're working separate body parts. Let's say you do upper body, then tomorrow you can do lower body. But generally, I like for my patients to do full body and to have at least a day of rest in between. So let's say Monday, Wednesday, and Saturday, something like that. Okay. Now the in between days you can slot in some cardio, and I don't go crazy over cardio. 20 to 30 minutes of moderate cardio is fine for me, and then a day of mobility like yoga, stretching, tai chi. And then a day of just active, go out, go out for a walk with your friend, go out, for a bike ride, that kind of stuff. So that's kind of the structure that we give our patients, and that's what I encourage. In terms of, the specific recommendations, obviously you can get a trainer and there might be some videos and so forth, but in the podcast, we'll probably do a whole section on resistance training and what to look out for and how you plan out your own resistance schedules, because I want to make it helpful to people and I want to make it actionable, right? Because it's not just about the information. It's like, how can I take this information and make it actionable and impactful in my life and my family's life?
Great, thank you.
Joanne, and then Leslie, and then we'll wrap it up. Although I have one question. Go ahead, Joanne.
Your information is both impressive and in and of itself motivating. The nuances of what you have to pay attention to and not the stereotypical parameters we're used to using. I'm wondering about the issue of keeping people motivated and whether you've experimented with that and the progress people make if they work in groups, perhaps, or when they get discouraged, because this is a lifelong journey requirement.
Absolutely. We actually work long-term with our patients. We often see our patients weekly or every other week. We focus a lot on community building. Pre-COVID, they came in, and if you walked in my practice, you would mistake it for a community center, because that's what it would look like. People came in to exercise together. They came in for their balance class together. They would schedule with each other. Let's go for a walk before Dr. Loh's class and so forth, right? And during the COVID pandemic, we switched to online. So we have a format like this. I teach every week, one balance class. I teach a total of about 7 classes a week, if you count the exercise classes in there. And so patients are at different stages, so it depends on which night of the week. Once a week, there is just this general medical information, and the coaches work with the patients on their individual goals, health goals as well. So there's a lot of input from my team members. There's a lot of interaction between the community members in our patient population. So yeah, you're absolutely right. It makes a big difference to have that community.
Thank you. Appreciate it.
Leslie, the last question, except for one I want to sneak in.
Yeah, I wondered if anyone can come to your clinic, Dr. Loh, or do you have to be referred by a physician because you have a medical problem? Can you come to get more information?
Yes, the first step, we'll ask you to just call our front desk, and then you'll be scheduled into a free orientation that will tell you a little bit more about how we run the practice and so forth. And then we schedule an initial consultation. If you will just recall what I told you, that 88%, let's say 90% of Americans have metabolic dysfunction, and that by percent body fat, 90 to 95% of people in this country suffer from obesity, then I will just tell you this: it is highly unlikely you come to me and I will find you metabolically healthy. Which is why a lot of people don't come to me, but okay, that's a different story. I know she's such a downer, but I try to make you smile. So there's always something that we find. And the whole point is this too, right? That I'm going to show this bracelet. It says here, I don't know if you can see this: prevention is cure. So if I can prevent you from getting full-blown diabetes, that is the best cure, right? So we often, by our screening process with the DEXA and with the labs that we order, we're able to pick up on the person at risk, 10 years before they get the diabetes. So we prevent the high blood pressure, we prevent the sleep apnea and so forth, right? So we're able to do that because we test and we screen based on evidence-based sort of parameters, and we check the things that the current healthcare system is not checking, right, to make sure that we catch this early. And we do take Medicare patients. Someone asked that. And before you ask the question, Bruce, I just want to end with this, and then you can ask the question. Maybe it will be the same thing. But I thought I would share with you why I've been doing this work. Okay. To cut a very long story short, 2 years after I came out of residency, I was in a very busy practice of good doctors, but they were very burnt out. And so I was the lowest person on the totem pole when I entered the practice, and I got dumped with all the work. So I worked 128 hours per week, 120 hours, and there's 168 hours in the week. I got extremely burnt out, extremely burnt out. I'll give you an example. That year I had 1 week vacation, and I went down to Florida. The time I was married to my husband at the time. And we just checked into the room in the hotel, and he said, "Something wrong? What's wrong?" I said, "Nothing. Why are you asking?" He says, "'Cause you're crying." And tears were streaming down my eyes. And I said, "I think it's allergies." That's how disconnected and disembodied I was. Must be allergies. Because I didn't even notice I was crying. He had to tell me. I spent the whole week sitting really on the sand, staring out into the horizon the whole time, tearing. And I was like, this is really weird. Should I try Claritin? Should I try this? This is the kind of thinking that was how disconnected I was. Okay. Then I just went right back to work thinking that was a strange thing that happened. Months later, I was in my car, I was driving somewhere, and I'm in Boston, you know. Boston drivers aren't, many of them are in this area. Yeah, I hear this sniggering already. Okay, so anyway, I was at this traffic light, and this car in front of me, the light was red. And the minute that light flashed to green, I just, move it, right? And I was so stunned by that. I was very shaken. I had to stop. I pulled over, I moved and pulled over, and I sat there and said, who the heck was that? Who was that? What have I become? Right? And, you know, so I thought, oh, I'm 2 years out. I'm not gonna last. And I don't know how to keep myself healthy. And I'm a doctor. And then it's also impacting my patients, right? Because I can't be kind anymore because I don't even know what that means. And I needed to make, you know, so if I had worked in an office where I was stamping documents, I could probably have gone on, but this is impacting other people's lives. These people, you know, I take care of them and their families. So I had to make a very difficult decision at the time. And maybe you'll understand the weight of this decision. I was on an H-1B visa, and the practice was sponsoring me for a green card. And I had to walk, I quit. No green card for you, young lady, after all the years you've been waiting. And I became an illegal alien. And I didn't have a job, I had a mortgage, and I didn't know what to do. And then, you know, I started, you know, I did whatever I could. I worked in a gym, became a personal trainer, I taught spinning. Then they said, can you teach aerobics? Sure, never done aerobics. Went to the library, got a tape, watched it, memorized the tape with the music, left hand, right hand, and taught the class the same week. Taught English, taught anything, you know, moonlighted. It took me 7 years. I am now not an illegal alien, whew, right? But I couldn't leave. I couldn't. If anything had happened to my family back in Singapore, I couldn't have gone to see them. You know, for that book, I think I told you, I was offered the Rome Prize, could not go. I turned it down because if I left the country, I wouldn't get back in. So there were consequences, certainly, but I'm glad I made that choice, right? But it then forced me to, and I put myself through what I call my year of silence. I withdrew and I went to just a year of where I didn't hardly talk to anyone, and I needed to clear my head. And I'm a writer, so I was very selective about what went into my head. You know, even music, just instrumental, because I didn't want words until I could kind of have a clearer space in here. Anyway, and that was when I started thinking about, they never taught us anything about how to take care of ourselves, or really take care of our patients in med school. And I went back and started teaching myself, right? And reading the basic science and learning about nutrition and doing all that work. And that's where other aspects of my life became very helpful. So for example, the dance and working as a personal trainer. And now I can tell you about resistance training, right? And I can tell you the science of it, but also the practicalities. I teach the fitness classes. I correct my patients' lifting techniques, for example, that kind of stuff. So we use narrative writing in some of the things that we do with the patients and so forth. Meditation, which has been really instrumental in helping me clear my head, right? So I found that really important. And so I bring that to my patient population. So, yeah, go ahead.
An extraordinary story, truly, and you're an extraordinary person. And we're so grateful that you have given us so much of your time today. So I'll save my question for your podcast. It was really about sleep. In one of the things that I saw, one of the podcasts I saw you talk on, or presentations, you talked about the problem of disruptive sleep. So it's something I'm trying to conquer, and I know how critical it is to all this. So, but I don't think I don't want to burden you any further.
I plan to spend a whole month on sleep. And the way I plan to roll it out is a once a week, 1 hour session, because I don't want it to be here, here are 5 quick tips on, I want you to really understand what's going on in your body and in your kids' bodies, yeah, your family, your mom. I want you to understand that, and I want you to know, what you can do about that and how you can change that. And there are so many things that you can do, and they cost you nothing.
Well, this has just been fantastic. Thank you very much for your time. I know I applaud you, and I hope.
Thank you. Can we do a happy dance?
Yes.
All right, I got you moving.
There you go.
Big hug.
Take care. Be well. Be well, everyone.